Stewart.
All right, well, listen, I'd like to call to order the July meeting of the Health Policy Commission. We have some important information to present and some policy issues to discuss. Before I go any further, I would like to approve the minutes of our June 8th meeting. As in the past, we need to have a roll call, which our great Deputy Executive Director, Colleen Estemeyer, will take us through. But before we get a vote, are there any additions or changes to the minutes? If not, Colleen, if you will take us through this.
Absolutely. Do I have a motion to vote on the minutes?
So moved.
And a second, please.
Second.
So much. Okay, we'll start with a roll call vote. Chair Altman, how do you vote?
I approve.
Vice Chair Cohen.
Approved.
Commissioner Berwick.
Approve.
Commissioner Blakeney.
Approved.
Commissioner Cutler.
Approved.
I'm going to ask Commissioner Foley to abstain and Commissioner Kreider as well because they weren't in attendance at the last meeting. So moving on to Commissioner Haupt.
Approved.
Commissioner Master Giovanni.
Approved.
Secretary Sutters.
Approved.
And Commissioner Roeder.
Approved.
Thank you.
Very good. Before we proceed with the official business of the commission, I do have an announcement to make. With sadness, but a sense of satisfaction, I want to indicate that this will be my last meeting as the chair. This has been an incredible opportunity for me. As many of you know, my official position reached a conclusion a year or two a half ago, but the governor has been so generous, given the complexity of the pandemic and the activities of the commission. He's allowed me to stay on as chair, but it's time and I need to step down. But I do that with such a sense of accomplishment. It's been such a pleasure to work with you, my fellow commissioners. You know, I've been very fortunate in my career of having had opportunities to work with a number of very important organizations, but none of them come close to what we've accomplished here in Massachusetts in the commission. You've been a wonderful group to work with. We've managed to sort of work our way through some incredibly complex situations and to do it in a way that was both kind and professional. It's been a great opportunity. And what can I say about our staff? What a wonderful group. David, you've been just superb as an executive director with Colleen behind you and in front of you. And the senior staff with everyone just putting together just wonderful quality outputs in terms of reports and so on. I could go on for a long time, but I know we have an important meeting and I hope I'll get an opportunity to meet all of you in person. But before we move on, I particularly want to thank the secretary, Mary Lou. You've been just a superb colleague, friend, someone who I could rely on. And I know you have comments from our governor. So before I totally collapse, I'm going to turn it over to you.
Stuart. Stuart, the governor is extraordinarily grateful for your service to all citizens of the Commonwealth. it was very important for him that you, being the inaugural, but having 10 years as the inaugural head of the HPC. So extending the term was just the right thing to do, just completely the right thing to do. And he always has known that you have had the heart of every resident of the Commonwealth on the highest quality of healthcare and tackling healthcare cost. So today is a celebration of your accomplishments. It is poignant as you step down at this time. And Stuart, there will be a non-virtual celebration of your accomplishments. And I know David and Colleen and all of us will gather to celebrate and acknowledge all of these contributions. So it is, and David Cutler and I, with you, are the inaugural members of the HPC board. So
That's true, yeah.
right?
Yeah.
Yep. So
Yeah.
we honor you today and are grateful on behalf of the citizens because you created and envisioned, you implemented the vision of the law. And as you said, extraordinary board, extraordinary staff, but it's extraordinary leadership, Stuart.
Thank you.
So from my heart to yours, I'm hugging you virtually.
Oh, thank you, thank you, thank you.
So do you want me to make the announcement, Stuart?
Sure, why not?
Okay. So very important for this to be Stuart's meeting. And we're announcing, the governor is announcing that Deborah DeVoe, who is the recently retired as executive vice president at BI Leahy and has an extensive career in the Commonwealth of Massachusetts, including 18 years at Blue Cross Blue Shield as the chief operating officer, is the incoming chair of the Health Policy Commission effective tomorrow. So we welcome Deb tomorrow, but today we celebrate and acknowledge Stuart's extraordinary role.
Well, I can't be more pleased to have Deb take my place. What a wonderful appointment. She's a tremendous asset. And how ironic, you probably don't even know this, Mary Lou, but I think I got this job in part because of Deb. And we were a team together of a group of the important players in our healthcare system back. And it was as a result of that group that I was asked to become the chair. So what a great selection. I couldn't be more pleased. So I guess, David, now you wanted to say a few things?
I do, Stuart. Thank you. On behalf of the HPC staff, both past and present, I want to thank you, Stuart, for your leadership, wisdom, and friendship these past 10 years. For the past decade, you have led HPC to take bold action to reduce healthcare costs, and you have helped make Massachusetts a model for the nation once again. And you did it all with your trademark even-handedness, intellectual rigor, and of course, good humor. Your contributions to healthcare policy in Massachusetts and the United States are beyond measure. So thank you for your service. You will be missed. As the secretary said, we are looking forward to celebrating with you in person this fall, as well as celebrating the 10-year anniversary of the HPC. And speaking of meeting in person, I'm sure most of you remember that we used to meet in person for our board meetings here at 50 Milk Street at the HPC's Conference Center, which as of today will be known as the Stuart H. Altman Conference Center. in honor of the HPC's inaugural chair. Finally, I just want to say thank you, Madam Secretary, for your announcement on behalf of the governor, and we really look forward to working with Deborah, to continue to advance the HPC's mission into the second decade. Thank you, Stuart.
Thank you, David. All right, well, I get to chair this meeting, so why don't we move on and officially ask you as our executive director to take us through the remaining parts of the agenda.
Great. Thank you, Mr. Chairman. So we have just one major agenda item today for the board's discussion, which is a conversation regarding the upcoming policy recommendations in the 2022 Healthcare Cost Trends Report. So on the next slide, we have been presenting the research and cost trends information to you over the past few board meetings, but wanted to shift the conversation today to begin a conversation about the policy recommendations that we plan to include in the report. Just so you know the timeline here, hope to get your input and input today, which will help inform the staff's development of the final report, which will be circulated to commissioners over the summer. And then we would plan to vote on a final version of the report with the recommendations in September. So no vote here today on the recommendations or on the report. This is really an opportunity for discussion and input as we develop the set of recommendations for this report. As we considered the recommendations this year, we were very cognizant of the fact that this is the 10-year anniversary of the state's cost containment law, and therefore I think really provides an opportunity to reflect on some of the past policy recommendations and the progress or lack thereof that we've made in order to inform where we go next. And so last year, we at the HPC in our cost trends report advanced a bold, comprehensive set of policy recommendations that were really focused on the intersecting challenges of cost containment, affordability, and health equity. And while we've made some progress on these recommendations, clearly more action is still needed. So what we've prepared for today's conversation is to revisit last year's recommendations one by one and share with you a non-exhaustive catalog of activities, both legislative, state agency, and other states that are relevant to our recommendations. And I'm going to pause after each recommendation to open it up for conversation to see, does this recommendation, is it still relevant for our next year's recommendations? Are there additions or changes that we as staff should consider or that commissioners recommend? So you can see at the bottom here, these were our 5 big recommendations last year. And so what we'll do, as I said, we'll go one by one and open it up for conversation on this progress report. All right, great. So let's just dive right in. So our first recommendation was around strengthening accountability for excessive spending. And so the recommendation said that we were hoping to see legislative action that would strengthen the mechanisms of our PIP performance process, including expanding the metrics that can be used for referral into the process, increasing financial penalties for above benchmark spending or for noncompliance, and considering other tools that may reflect and respond to the underlying variation of provider pricing. So on the next slide is our summary of some of the key activity on this recommendation. On this recommendation, there has not yet been legislative activity adopted this session to advance this recommendation. And then in the next category, you can see we did want to highlight, however, that the Group Insurance Commission, as part of its procurement for health plans for state employees and retirees, did incorporate spending targets into that procurement that are in line with the healthcare cost growth benchmark, creating, we think, another opportunity for accountability, in this case, for health plans to meet the healthcare cost growth benchmark. There is some notable activity in other states, which I feel I wanted to highlight for the board. And this is recent activity in the past year. So first, want to highlight that California, just on June 30th, passed a law which established a new Office of Healthcare Affordability. This office, in many ways, is mirrored after the Health Policy Commission. I looked through the bill text yesterday and saw sections that I will generously say were inspired by our statute. But they went further in many different areas. And one of the areas that they went further is while the office has the ability to establish a healthcare cost target, is what they call it, it goes further than our current law by authorizing the office to also assess financial penalties on payers or providers that exceed the healthcare cost growth benchmark, and amounts commensurate with the failure to meet that target, and in escalating amounts for repeated or continued failure to meet that target. Would note now that with the addition of California and New Jersey, there are now 7 states with healthcare cost growth benchmarks or targets that were modeled after what we pioneered here in Massachusetts 10 years ago. And these 7 states collectively represent 70 million US residents, or 1 in 5 US residents nationwide. Stuart, this is to your sense of accomplishment and your leadership. This model has been replicated in many states and is impacting healthcare costs now across the country. The second highlight second state I wanted to highlight here is Oregon, which has had a benchmark in place. They actually have now strengthened that benchmark by requiring payers and providers to complete performance improvement plans. That's very similar to our current statute, but goes further in allowing their office to impose financial penalties on payers or providers that exceed the cost growth target without reasonable cause. And then finally, in the top right-hand corner, you can see HPC action. What have we done on this recommendation in the past year? Well, we have required our first performance improvement plan, the first in our history of MGB. So this is the progress report on this first recommendation around strengthening accountability. And I'm going to pause here and see if there are questions, comments, feedback. Is this a recommendation that we should continue to pursue in this year's report?
All right, are there comments or questions from this is a very important provision, and I welcome any comments of my commissioners. I think what California has done, and I particularly have been looking at Oregon as well, is the idea that there may be what might be thought of as phase 2 in terms of the benchmark, in terms of strengthening our capacity. And that's what we've recommended to the legislature and the governor. And there's been a lot of interest, although, as David pointed out, we haven't reached an agreement. Excuse me, what's going on?
Keep going, Stuart.
I do want to, from my vantage point, recommend that this provision be continued in the next go around of our recommendations, but I want to get comments from my fellow commissioners as well. Anybody want to jump in?
Stuart, it's Chris.
Hi, Chris, please.
Well, 2 questions. First is, what are, beyond California, New Jersey, and Oregon, what are the other 3 states?
So the states are Washington, Oregon, California, Connecticut, Delaware, Rhode Island, Massachusetts, New Jersey.
Right. And David, have they increased their correspondence with you in the last year? Or, I mean, could you give a little playback over the last 4 or 5 years of what the cadence of communication among you you and your fellow executive directors? Or is it, I presume that the activity's going up, but is it twice what it was? Is it 3 times what it was? Can you give a little bit of commentary there?
Yeah, absolutely. So we have been in regular communication with these other states. And in fact, Milbank Foundation has supported kind of a technical assistance program for what we call the benchmark states. And so we just had a convening earlier this summer where we all were able to meet in person to discuss the progress of the different states. I would say among the states, as noted here, some are continuing to evolve and advance their model, but there are very different places. For example, just this year, Connecticut codified their benchmark into their statute. Previously, it was kind of operated under an executive order. And New Jersey, I believe, is still under an executive order. So the states are in different places in their journey, so to speak. But it has been, I think, a tremendous benefit among these states to share lessons learned, to share, ways of accessing data, and also to share progress and some of the challenges. And I think this will continue to be hopefully a growing cohort of states working together on these similar topics. Professor Cutler?
Thank you. So I have a couple of comments. One is just in response to Chris. I've actually had a number of conversations with some of these states as well. One of my friends in California was intimately involved there, and so I spoke with people there a number of times. And I also just recently met with people in Rhode Island who are considering what to do about the fact that inflation is now very high and how should that affect their benchmark. And I've had contact with a few other states too. So there is a lot of learning that's trying to take place. And I do think that many of the states, one of the parts where they think that our legislation was a little bit weaker than they want to be is in exactly this area, which is the accountability for excessive spending. And so many of them are thinking about stronger policies than that. I particularly think we ought to urge the legislature to do this because I'm quite worried by what we're hearing about providers coming in and saying, we expect, we coming into insurers when their rates are up, which some of them are this year, and saying, we want very, very large price increases because, we lost money during the recession. And so we need to make it back from you now. And we don't think Health Policy Commission basically is going to do that much. So you should give us increases not of 1 or 2%, but of 7 or 8 or 9%. And I don't know where those will come out or how common that is, but I think we're going to need going forward some stronger capacity to deal with this, including the ability to both do more performance improvement plans, but also to impose penalties beyond just the delay of the performance improvement plan. And so I'm looking forward. I think this is going to be a really important issue for us.
Thank you. Patty?
Yeah, this is as much a question as anything else. I know the concept has come up in the past of having a variability in the benchmark rate. And would this be the place to discuss that? Incorporating something relative to variability rather than a one size fits all?
Yeah, absolutely. I think the recommendation from last year certainly alluded to that with the concept of, if you return to the previous slide for just 1 second, in this last bullet around additional tools with the benchmark to reflect and respond to the underlying variation that we see in providers in particular and their pricing. And so that was, I think, alluding to that concept of having variability, but I think, open to the conversation, and maybe we want to be more specific in this year's recommendation.
Yeah, I think maybe strengthen it or being more specific, because it's not necessarily obvious to someone who isn't working with it all the time.
Hannah, can we go back to the next slide? Commissioner Berwick?
Thanks, David. Yeah, I want to jump on the same question that Patty did. So we're going to be looking at all 5 of these areas. I thought the variation one was the 5th, but if that's not right, Stuart, let's make sure that after we go through the 5, we zoom out and take a comprehensive look at the whole set and see if there's something missing. Because if we don't get stronger on the variation issue that Patty raised, I think we're probably going to miss the boat.
Great. That sounds like a good plan.
Yeah, that does sound like a good idea. One of the areas we have to figure out a way to both be tougher in some sense, but recognize that trying to sort of figure out what every rate is going to be, having done that once or twice in my lifetime, that is a tall order. And one of the recommendations that has been suggested by many of the more senior analysts in the country is going towards what we talked about last time, which is putting price caps on the top, but not trying to sort of figure out every particular rate. And I know a number of states are looking at similar kinds of activities. And in answer to your statement, Chris, I too have been very much involved in several of the states, particularly California and Connecticut and Delaware and Rhode Island. And in some sense, they've sort of gradually gotten ahead of us, which is good. Let us learn from them, just like they've learned from us. So I look forward to the kind of discussion that's going to take place in the legislature about these issues.
Commissioner Foley?
I just off what Patty referenced earlier and Don added to, clearly, I think that's a really important thing that we should strengthen in the next recommendations for the policy recommendations for the cost trends report. You know, we do have the one line in there for this section about, you know, consider additional tools. Maybe we should recommend tools that we think would accomplish the variability. As I say a lot, it's not all the spending is the same in the market. And so how do we give some ways for the legislature to think about that and be clear about what the tools could be or options like we have in some other areas of the report? I think that could be one area to really strengthen from this report to the next report. And my question about that was, does California or any of these other states, have they figured out ways to do that? Or is it the same approach to the benchmark? Is there lessons we can learn from how they've done it? Or would this be kind of new ground that we would be taking on here in Massachusetts around the variability of the benchmark?
I would say, thank you, Tim, and I appreciate those comments and agree. In response to the question, I would say generally the states have copied our approach, which is that the benchmark is a single figure measure, you know, statewide, and that in determining who should have to do a performance improvement plan, that is really where the consideration of other factors is included. So it's the same number applies to everyone, but when determining whether a PIP is warranted or not, that's when other contextual factors are layered in. But I think, you know, we have discussed, is there a way to bring some of those perhaps contextual factors into the process earlier than when an entity may be subject to a PIP? Commissioner Mastrogiovanni?
Thank you. I basically just want to echo what everybody else has said, but in addition to that, I've talked to folks in a number of organizations, and they're asking for 10%, not less than that in terms of increases. And that's something that, you know, we really need to look at, and we don't want to fall behind other states that have basically replicated what we have and then taken a few extra steps. We want to stay ahead of that game. And I think it's important for elected officials to see that and to take action as well, and to provide the commission with the tools necessary to ensure that we're able to manage it.
Thank you.
Why don't we do this, David? Why don't we continue on? And
Yep.
then if others have comments about this, we can circle back as
Yep.
Don pointed out.
Yes, we can always return. So let's move on to the second recommendation, which is around constraining excessive provider pricing. We have identified for many years that prices are the main driver of healthcare spending, both in Massachusetts and across the country. And so this recommendation included 4 kind of sub recommendations. The first was to complement that statewide benchmark with a price cap for the highest price providers. So only targeting those providers or those service areas with the highest variability in pricing. And also to consider price growth limits, which would limit the annual growth in pricing either for a service line, insurer, or provider to reduce unwarranted price variation and promote equity. The second was to limit facility fees and require site neutral payments for services provided at hospital outpatient departments. The third was to enhance the scrutiny and monitoring of provider expansions, and specifically in the ambulatory care space. And then finally, we recommended that the state adopt a default out-of-network payment rate for services provided kind of in an out-of-network situation, that there would be a default payment rate tied to the median commercial rate for those services. So on the next slide, we have our progress update. So here in the legislative activity, a couple of important advances. First, I want to highlight the Baker-Polito administration's bill and the secretary's bill, a comprehensive healthcare bill, and act investing in our healthcare future, which was filed in March 2022 and did include some key measures to address some of those sub-recommendations, including real limits on hospital outpatient facility fees was included in that bill. They did include a default rate for out-of-network services as recommended, and also included confidential reporting of provider price changes. Another important bill that passed the House of Representatives last year, an act enhancing market review process, proposed enhancements to our scrutiny of material changes to provide greater transparency and accountability for other types of changes in the marketplace that may not currently fall within our MCN progress. To date, neither of these bills or these provisions have been adopted by the legislature. In terms of activity in other states, importantly, Delaware did pass a law which established a hospital price growth cap. So another state that has had a price growth cap in place for many years is Rhode Island. Rhode Island has evidence that this price growth cap has made a meaningful difference in their healthcare cost growth trajectory while having no impact on the quality of care delivered. So Delaware was inspired by Rhode Island and has implemented a hospital price growth cap. With regard to market reviews, Oregon has also established a process for reviewing material change notices and transactions, which again is very similar to our process. It's an MCN is filed, they have a 30-day review, and then they may initiate a longer review. It is very similar to our process, with, however, the additional authority that the office can reject a proposal at the end of their review, or can approve a proposal with mandated conditions. So our process ends with a report, perhaps a report to the Attorney General's office and the Department of Public Health, but there are greater authority given to this review office. And then finally, Nevada and Colorado recently have been following the lead of Washington in moving down the path of a state public option plan, and have used provider payment rates as a percentage of Medicare as kind of a backstop to create the savings in that public option plan. Those public option plans are all still in development, but includes this concept of provider price caps as part of it. And then finally, with regard to the federal government, would note that this year was the implementation of the No Surprises Act, which prohibits surprise billing and resolves out-of-network rates through arbitration. We recommend a default payment rate, but nonetheless, this federal law has been ongoing in its implementation. And then I think somewhat related to this, CMS is issuing penalties and holding hospitals accountable for federal price transparency rules. We have, I think, conducted a lot of research in this area. As you may recall from past meetings, we have done the work to model what different price cap levels may be, depending on percentages of Medicare or percentages of kind of commercial variation. And so we've done a lot of research and reporting about how might one implement a price cap or a price growth cap. I had invited Limor Daphne to present on this last year. So that's been our main activity to date, is really doing the modeling and the data work to support some of these recommendations. So I'll pause here too. There's a lot of subparts to this recommendation. So happy to kind of open it up and start with any piece of it. Commissioner Berwick?
Well, yeah, so comments, I jumped the gun a bit.
Sorry.
Because this discussion just folds right into the first one we had about flexibility. So I welcome now additional comments about what David has just said.
Go ahead, Commissioner Berwick.
Thanks, David. Three comments, really questions here. One is, should we be doing something to synergize with the CMS price transparency rules? They were sort of ignored first year. They're leaning in on that. Do we have enough price transparency in the Commonwealth? And there anything we want to emphasize there? First question. Second question is sort of technical, and I think David Cutler and Stuart would be better able, but the way we deal with pricing is it kind of accepts, it isn't zero-based pricing thinking. We accept whatever the status quo is and then examine price raises above that. Is there anything we should be thinking about? Is it at all conceivable that we could be more aggressive about looking at the baked in prices that are already in the whatever the rate sheets are now? Those are two questions. My third is the most important, though, of my points, which is it time, or have we already done this? Is it time for us as a commission, David, to look at the Maryland model and examine what it would mean to bring Maryland to Massachusetts? So many people ask about it. It's widely cited. Maybe we should be looking at that this year and asking the big question about whether that overall rate setting model might be good for the Commonwealth.
So I'll offer a few responses, but Stuart, Professor Cutler and Chair Altman, please weigh in as well. On the first around hospital price transparency, I think that is an area that we can look at and make a recommendation back to the board. We did do a kind of a scan of our Massachusetts hospitals and where they are putting their price transparency information on their website and in what format. And so may have some, best practices that we may want to recommend about what's the best way to make sure that information is both transparent but usable. So more to come on that. I think with regard to the acceptance of kind of the baked in levels of pricing, I do think the concept of a price cap on the highest price services or service lines or providers could get at that. If you were to say, put a price cap at the 90th percentile of where things are right now, that actually would create some savings and would only really bring the high end down. That's not kind of comprehensive across the board, obviously, but that would be one way that paired with a growth cap may actually address the underlying pricing. And third, with regard to Maryland, Maryland, I think as you know, is such a unique model and such a unique history of how that waiver with the federal government was negotiated. And so, I think always open to learning lessons about from other states, and maybe it's not the Maryland model here, but maybe something inspired by Maryland that could be adapted for our market and for the current interests of the federal government as well, because they would need to be partners with us on an endeavor like that. But others feel free to weigh in on those points. Commissioner Cohen?
Yeah, David, I think a continued focus on price is certainly a recommendation we want to consider. But I also realize some of these, the out-of-network facility fees, these are things that we've been highlighting year after year after year. And I'm almost wondering whether we need to say how many years we've been raising these to bring attention to the fact that there hasn't been any real action on some of these things.
I would like to comment on Marty's statement as well as on Don's. First of all, I do believe we need to be looking more at the price transparency. And while I'm not the biggest fan of it, I do see value in it. And it is important that we look to what extent we could, from the Massachusetts point of view, become a leader. And we have the best data out there. So I would strongly recommend that we continue to work in that area. Don is absolutely correct. The whole structure of the pricing system has taken, I think the best term, bizarre characteristics that are unfathomable if you take them apart. The problem is, having been part of zero-based pricing of some sorts, it's very difficult. And that's why Massachusetts, as well as most states, have sort of been reluctant to sort of break into it and look at rates of increase. To the extent that we could do something about the structure, I would strongly be supportive, but it's very difficult. And then we get to Maryland. Having spent the better part of 10 years of my life in the Maryland system, I share what David Sells just said, is that it is a unique situation where the federal government, for a variety of reasons, has been willing to send Maryland billions, not millions, billions of extra dollars in order to maintain some degree of price comparability between what Medicare pays and what private insurance. Every state that I know of has looked at Maryland and then walked away from it and adopted the Massachusetts model because Maryland is so unique. I do like the Maryland model, but it requires the federal government to come in a major way and essentially send, in the case of all states, tens of billions of dollars. So I think for practical purposes, each state is going to have to develop its pricing structure along the lines of what it existed before and try to slow the growth. And that's why I've been supportive of the model that David articulated, which is to put caps on the biggest increases and allow those at the bottom end to come up a bit. But again, the Maryland should not be totally ignored. And there are a lot of aspects of it that we could benefit from. But in total, it's going to be very hard to bring comparability between what Medicare pays and what private insurance pays, given how out of whack the two of them have become. Other questions and comments?
Professor Cutler?
I just want to echo a comment that a couple of people have made, which is that in addition to thinking about the prices, we need more flexibility with respect to the implementation of any type of target, or either spending target or price target across different providers, because the uniform policy is really quite constraining. And just since we're in remembrance mode, it was the hope at the beginning of this that this legislation would seek to compress prices across providers. It hasn't done that. To be fair, prices were spreading apart, and it's probably constrained the extent to which they spread apart, but it has not at all compressed them. And that has been, I think, one of the issues on which we were less successful than we hoped. And so therefore, as we move forward, we ought to think about expanding the toolbox to allow the HPC to have the ability to set policy that's not uniform across all the institutions in the market. So that's one dimension here. I also just want to raise a second issue here, part of which is immediately relevant here and part of which is not, which is it's sort of weird, and we've run across this, that we have some modest amount of say on pricing and consolidation and so on amongst providers, but not amongst insurers. And so that's a sort of the split with DOI can constrain us, because then, for example, it's hard to fit in what's going on in one market with what's going on in the other market when they're tied together, but we don't have any say over one. And so as we think about the pricing side here, it might be worth thinking a little bit about the insurance pricing end, because that is related, my watch doesn't understand, but hopefully others will, because that's related to the provider end. And so some flexibility on that count could also be helpful.
Well, I think, Professor Cutler, you've teed me up to move directly onto the next recommendation, which is focused on health plans. So let's maybe move on to that one, and again can circle back if we need to. So the next recommendation was really health plan focused, and here too we had a number of sub recommendations. First, around setting affordability targets and standards in the review of health plans rate filings. Second was to overall improve the health plan rate approval process, allowing for greater transparency and public participation. The third was to reduce administrative complexity amongst our health plans. Fourth, let's improve our benefit design and cost sharing. And then fifth, finally, increase the adoption and effectiveness of APMs. So a lot here. So let's show some of the examples of where we made some progress on this recommendation on the next slide. So first, in the vein of kind of both reducing administrative complexity and supporting the adoption and increase of risk-based contracts, would note that the administration's bill would codify a current quality measure alignment task force, which works to align quality measurement for risk-based contracts. No legislative proposals have been adopted to date during this session. However, I do want to highlight that the Division of Insurance has proposed regulations that would improve their health insurance rate review process, allowing for that greater transparency and public participation, and moving towards an annual review process. So that is a tremendous advancement on one of those key recommendations that DOI has been moving forward. Two others to share: the Massachusetts Health Connector is implementing cost sharing reforms for chronic conditions. So in the recommendation around kind of improving benefit design, the connector is really leading the way and thinking about how to reduce the cost burden for certain patient populations that are disproportionately impacted by these chronic diseases. And then again, just to mention that the Quality Measure Alignment Task Force has worked to continue to push forward quality alignment. In terms of activity in other states, I think most interestingly, Delaware explicitly is now incorporating healthcare affordability standards in its insurance rate review process. This is inspired by and similar to the Rhode Island law, which again allows for the consideration of affordability when rates are under review by their division of insurance. California, as part of their new Office of Healthcare Affordability, is also setting statewide goals for the adoption of APMs or risk-based contracts, and they include standardized quality and equity measurements in their reporting. And there are many other states that have been working on quality measurement alignment. Two things I wanted to highlight that the HPC really worked on this past year. One, we partnered with NEHI on a project around reducing administrative complexity. And so that was a great partnership, and that partnership continues. And also in terms of our dashboard and our report, we included affordability measures as part of that to track, how are residents of the Commonwealth being able to access the care that they need without cost being a burden. And so we're tracking those figures more closely as part of our annual report. So I'll pause here and open it up for comments and considerations as we think about the role of health plans in this effort.
David Cutler, did you want to continue your discussion about the health plans?
I do. I do think we could think about it here. I want to. The reason why I didn't jump in is because I think one area where we have not done enough in total is on trying to reduce some of the underlying costs structure in the system. And there are two areas. So I was going to bring this up at the end, but I'll do it here. And I think there are really two areas that strike me. One is on the administrative cost end, where we've done a little, but I think not as much as we probably could have done. I would say we were building up some speed, and then COVID happened, and understandably that made it be difficult for us to carry on here. And I'm hoping we can pick up more speed. And then the second area is something that Chris Kreider has spoken a lot about, which is taking advantage of changes in the way we now know how to deliver medical care to be cheaper. So, at home versus in institutions and in ambulatory settings rather than inpatient settings and all of that. And I think on each of those two, we've pointed out that there's tremendous opportunity, but in my personal opinion, we probably haven't done enough to push the ball forward. And personally, I think I've not probably done enough, and I expect as a commission, we have not done enough. So I wanted to come back to that at the end, and I was sort of holding those two thoughts, but this seems like maybe an okay time to raise those two issues.
So I can take the baton that I think David has given me an opportunity to pick up. And I think I'm maybe an outlier on this commission, but I think the focus should be go well beyond alternative payment models, which are complicated to administer and involve all kinds of reporting, and instead focus on a process that Don Berwick and I lived under as physicians a long time ago, and that is capitation, true capitation, where a price is set and it's on the providers to manage that risk. So a few points. David said, echoed what I described, have said since the pandemic began. Telemedicine and remote monitoring are tremendous tools to take care of patients better, quicker, cheaper, and safer outside of the nosocomial world of hospitals. Yesterday, probably most of us read the article in the Globe that MGB was committing to expand their home health unit. I think the quote I think I saw was that up to 10% of the beds of the care, it wasn't the beds, they weren't talking about shrinking beds, of the care could be delivered outside. And my response to that is, how about 30%? I mean, what we have here are rigid business models that need to change. And I'd go so far as to say 2023 is going to force dramatic changes. It's not just problems in nurse staffing or labor costs in general or inflation. It's the loss of investment income. The big rich systems have operating margins that allow them to carry on despite losses in their investments. That's not the same for the smaller systems and community hospitals that have used investment income as ballast on their balance sheets for the last decade. That's gone. That is GONE. So and bond prices are changing. So short-term borrowing for hospitals is going up as interest rates go up. You overlay recession into that with I'm not an economist, but I can't see good happening. And so hospitals, I think, it's primarily hospitals. It's not the ambulatory sector, but hospitals need to change their business models. And I'd like to put that on the table and say, can anybody argue that that is not the case? No, I don't think so. I think we would all agree they have to. They don't want to. And in fact, price caps, if you lower prices, you increase volume. I'm Stuart, I won't say what administration you were in when price controls came about. They don't work. They just don't work. And the Maryland story, I think, is an example. It requires enormous federal subsidies. So when I say I'm a black sheep, I think stricter regulations leads to less resiliency. And I think the hospitals, I think we could call the hospitals in as a commission in good faith and say, what's your resiliency plan for 2023? It looks like there's a lot of dominoes that are falling the wrong way. What's your plan? And instead of telling them what we think they should do, is listening to what they think they should do under the circumstances of way beyond austerity. So anyway, that's a little bit too much of a monologue, but it was a pretty good setup, David. So I had to take advantage of it. But I'd love to open up and propose that this commission call the systems in and say, how's 2023 look? What are you doing about it? We want to work with you. But this looks like real trouble for 23% of Massachusetts GDP. Okay, that's it. Monologue over, but please push back. Tell me I'm wrong. My wife does it all the time.
Other comments? I mean,
I see two more hands, Stuart. Commissioner Mastergiovanni and then Commissioner Berwick.
Thank you. It's interesting what you said, Chris. Having been in multiple industries, I'm finding the same type of issue in the healthcare industry as I've seen, for example, in the computer industry. And I can go back a lot of years when the PC was introduced. And let me tell you, the PC was not a very popular product for companies like Digital Equipment, Prime Computer, and Lang Laboratories. I can go on. And they're all out of business today because they wouldn't change their business model. They stuck to the existing business model and they fought to stay there. I see the same thing in healthcare. When I look at community hospitals and I look at some of the larger institutions today and what they're doing and some of the financial issues they're running into, they're not willing to look beyond how they currently do business. And it's a serious issue. But how do you get around that? That I don't know, but I think that's an excellent point you raised.
Commissioner Berwick.
Thanks. Chris, I don't think you're wrong. I don't know what to do about it, but two points that you and David are stimulating. One is, if we are headed into the kind of almost emergency conditions that Chris is talking about, and I see the same, I must say, I think we're really going to possibly into trouble. The commission should try to get ahead of it. That is, we're terrific at, we've got the best analysts in the country, retrospectively. Could we do anything predictively now that builds on Chris's concerns and says, how we would get ready for possible scenarios? The second that I think Chris and David are both raising in my mind is the commission authorized to, or do we have the capacity to do what I would call large scale modeling projects, looking at alternatives and alternative futures? Chris puts on the table global, capitation as the model of payment in this state. I personally believe that is the only way out, but I don't have the skill to look at it and model it and say, what would it really look like? And how would we compare that to other states? If we keep working at piecemeal improvements, pricing controls, more accountability, and so on, we're doing our job, but it might not be up to the task of the big thinking that David and Chris are raising. So it's just some thoughts.
Stuart, any final thoughts on this?
Well, I am so reluctant to sort of get into the middle of this debate right now, but since this may be my last opportunity, the truth of the matter is nothing works perfectly, and most cases of interventions don't work well. But first of all, I would take Chris on that when you ultimately looked at what happened in the 1970s, we had a flattening of the rate of growth in spending. And it wasn't until the 1980s when we let everything go that prices really grew. So some degree of price controls in terms of a better way of doing it is not the worst thing in the world. The other thing I would say about capitation, which I was a fan of, is that, Chris, you ought to read the 1990s. That's what the Clinton plan adopted, and America rose up in opposition to it and destroyed it, because basically what you were saying, first of all, it requires a massive restructuring of the delivery system and moving millions and millions of people out of their traditional way of getting health care to something that so-called experts believe is better, and Americans didn't like it. And B, it required the delivery system and whoever was running the plans to say no to things that the providers, their individual physicians, said they needed. And so what sounded like a great idea in the beginning of the 90s became a disaster by the end of the 90s. So this idea that somehow capitation is the vehicle for the future, boy, read the 90s and
So Stuart, I'm gonna come right back at you, and it's great to get you engaged in this, your last chaired meeting. I don't think the past is prologue. And the reason why is that the 90s had so many other factors. It was a time of big economic growth. And healthcare cost was way down the list. Retention of employees was probably much higher for companies that were basically driving the insurance system. The Federal Trade Commission did not allow physicians and hospitals to band together with capitated products. Systems didn't exist. I mean, I was doing capitation deals almost on the back of a napkin to say to groups of specialists, okay, let's talk about what you're delivering piecemeal with a already complicated billing and coding process, and let's bundle it up and create a window of expected utilization and pay you in advance. So we now have computer systems that are extraordinary and data that is extraordinary to be able to model tight contracts. So I don't think the past is prologue. But more importantly, I think the future is really bleak. And I don't have a crystal ball. Maybe we avoid the stagflation of the 1970s, which I think is probably the reason healthcare costs did not spiral until the 80s. I leave that to the economists to look through the retrospectoscope. But if it's going to be bad, and we all think it's going to be bad, and maybe we all don't. I've heard from Don and Ron, and I guess in part from David, but not from other members of the commission. If we think it's going to be bad, I think we should get out in front of it. And again, we I think have the power to call in the systems executives, the payer executives and the provider executives and say, hey, how do you see it? Do you see a rosy future? That's great. If you don't see a rosy future, what are you planning to do about it? And how can we work together with you as one of the biggest purchasers of healthcare in the state, and certainly the biggest employment system in the state? So I'm digging in. Sorry.
Thank you, Commissioner. And I guess I would just, as a side note that we'll be talking a little bit about this at the end of the meeting, but we do have our 10th annual cost trends hearings this fall. And so we'll want to think about what themes and topics we want to highlight in the context of that cost trends hearing. So there may be some intersection with some of these conversations. All right, I'm going to keep us moving, and I'm just going to quickly, I'll do my briefing on the last two together, and then we can stop and we'll have gone through them all and have further conversation. So the fourth recommendation was really about embedding health equity lens into our work and ensuring that our efforts on cost containment and affordability are also aimed to reduce longstanding disparities in health outcomes. And so here we suggested three sub-targets or three sub-recommendations around setting measurable goals to advance health equity, continuing to address social determinants of health, and improving data collection. So here, this has been, I think health equity has been a primary focus of a lot of activity in the past 2 years and in the last year as well. On the next slide, you can see we did not even attempt to try to catalog all of the activity that has happened in this space. There's been a lot of activity in the Massachusetts legislature through the budget and through ARPA and through other activities and bills that have included equity provisions. I would highlight in particular, the Mass Health proposed 1115 waiver, which really includes a very strong focus on advancing health equity, including measurement of health equity advancements and reporting, and ultimately payments related to health equity. So that proposal M15 waiver, I think, will be nation leading in its incorporation of health equity principles. So hope to see that go through. A couple of other things here. The Health Connector explicitly included equity focused reforms in its seal of approval process. Mass Health is related to social determinants of health. Mass Health is strengthening its flexible services program to address SDOH and health-related social needs. With regard to data collection, this continues to be a process, a multi-agency process and a multi-stakeholder process. And so the Executive Office, through the Quality Measurement Alignment Task Force, brought together a health equity technical advisory group, which is working with EUHHS, CHIA, HPC, other agencies on creating some standard recommendations for data collection. So that technical advisor group is helping to inform those efforts. And then finally, I mentioned before the proposed DOI regulation that included improvements in the rate review process. Also want to note that it included improvements in requirements of health plan provider directories to include more information on provider language, race, and ethnicity. And we did not even attempt to try to catalog all of the activities in other states. The final thing I'll note here is there has also been industry efforts and private efforts to center health equity. And I want to specifically acknowledge Michael Curry, who has brought together a group of thought leaders and healthcare leaders in a health equity compact, which is really working to create a more systemic approach for the Commonwealth to incorporate health equity into all of its work. And then finally, the last recommendation was a grab bag. I'm going to highlight just two parts of it here that are of importance. One is on prescription drug spending and affordability, and the second is on improving primary and behavioral health care. So first on prescription drug reforms. Here on the next slide, you can see that there has been some legislative activity on this front. The governor's bill includes a number of pharmaceutical pricing reforms, greater transparency of PBMs, pharmacy benefit managers, and many of those same provisions are also included in an important bill that passed the Senate, the Pharmaceutical Access, Cost, and Transparency PACT Act. These proposals have not yet been adopted this legislative session. Mass Health continues to have success in their supplemental rebate negotiations with drug manufacturers. And we stand ready at the HPC should the need arise to work with them on an evaluation of value on a referred drug. Has not been necessary to date. A lot of activity in other states. Other states are really have been moving forward on prescription drugs reforms. I would note here, Washington established a new prescription drug affordability board with the authority to limit what health plans would pay for certain drugs. There have also been a lot of proposals to reduce cost sharing for insulin among states. That was also something included in our Senate's bill. And then finally, on the federal government side, the FTC recently launched an investigation into the pharmacy benefit managers, and both the U.S. House and the U.S. Senate have proposed different reforms on the pharmaceutical market, which has not yet passed. And then finally, on the next slide, was the update on the primary care and behavioral health care. This is a centerpiece of the governor's bill that he filed in this year, and which would increase the proportion of spending on primary and behavioral health care and includes monitoring by CHIA and HPC. That has not yet been acted on, but other legislation established payment parity for mental health delivered via telehealth permanently. That was in January 2021. And both branches have passed significant reforms on mental health care, which is currently in conference and under negotiation. On the state activity side, again, I think UHHS has been a leader in making investments related to the behavioral health roadmap, including some proposed the provisions of the 1115 waiver and support for the growth of inpatient psychiatric beds. Mass Health is also, we understand, requiring ACOs to do a primary care subcapitation model, which would again help support and invest in primary care and strengthen our primary care base. And then finally, we have been working with CHIA to be able to collect the data necessary to baseline, understand how much are we spending on primary care and behavioral health care, and how can we make sure that we can improve that over time. This concept of rebalancing the healthcare dollar towards primary care in particular has been a place where a lot of states have moved forward. So this is included in the governor's bill and was part of our recommendation, but both Delaware and Connecticut passed laws this session that would include the setting of targets to make more investments in primary care, joining a number of other states that have already made this a central part of their healthcare reform efforts. So I sped through those last three: health equity, pharmaceutical reforms, and primary care and behavioral health care. So we'll pause there and open it up and see if anyone wants to share comments or feedback on any of those three topical areas.
Comments of anyone? Yes, David.
Yeah, could I ask David, what is the mechanism of rebalancing when rebalancing is tried? This increasing the proportion of primary care versus non-primary care. You just say you're going to do it and monitor it, or is there some other mechanism that these other states are using?
So, for example, in the Rhode Island example, which I think was a pioneer on this was something that they incorporated through their insurance rate review process. So the health plans needed to demonstrate that they were increasing the proportion of dollars spent in primary care over a period of time. And they were successful in doing that. And that has been evaluated and shows evidence of being able to positive effects. The governor's bill again proposed setting targets and letting both providers and health, that would apply to both providers and health plans, that they would have an expectation of over time shifting more of the proportion of the dollars spent into primary care and behavioral health care. And then later, kind of in the process, there would be essentially a review and a compliance mechanism that if payers or providers had not succeeded in meeting those targets, they could be subject to corrective action. So in both cases, it's a matter of kind of setting some targets and setting some accountability, but providing more flexibility for the system itself to exactly figure out how to shift those dollars into those areas.
Are there other questions or comments?
Stuart, this is Patty. I just had a comment and a question. One is, I'm all for increasing expenditures through the primary care system, but PCPs nowadays, I know it takes me about 18 months just to get a checkup. So it's one thing to say we want to spend more money there, but if the capacity isn't there with the primary care physicians and you can't access a checkup or get in a timely fashion, that's a problem. And then layer on top of that our equity lens. And, I would love to see us be bold and provide some type of initiative to recruit more traditionally, populations that traditionally haven't accessed the system to have primary care physicians that look like them and speak like them and reflect the social norms that they grew up in. So I think it's a compound problem of not having enough capacity and certainly not having enough people who look like the populations that we're trying to provide equity for. So I don't know if we could do anything to be bold in that area in terms of trying to recruit more positions with more diversity in that population and make sure that we're well-staffed if we're trying to encourage the use of PCPs to make sure that there's enough of them out there to meet the demand.
Sort of building off of Patty's comment, I think workforce is something that we didn't focus on in 2021, but is something that we need to focus on this year, not only in primary care, but in other specialties as well. A lot of work is being done, particularly in behavioral health and partly in the waiver. But I think this is an issue that I know, Chris mentioned it's not the only thing hanging out there as a threat for 2023, but it certainly is one of them, and it's something we should focus on as well.
As a bit of an advertisement, we're having the virtual Princeton conference in October around the whole issue of workforce, Marty. Couldn't agree more. And we're going to try to address it. And I will make sure that all of my fellow commissioners are invited to that, which hopefully will either be October 19th or October 26th. But I will get back to all of you, and maybe you could use some of that as a jumping off point for the activities of the commission. I think you're right on. Workforce needs to be a very big issue going forward. Other comments or questions?
That's Chris. A couple of things. One is David Seltz. I think that there was, and you referenced it, alluded to it, legislation from Senator Friedman. I think the name of it was PC4U or PC something or other. And I think it'd be great if the staff could summarize for us, in a simple one page, what the status of that, what the content of that legislation is and what the status of it is. And secondly, I want to echo Stuart and Marty, the workplace adjustments that are likely to happen include the reality that nurse practitioners will take on acute self-limited care, and primary care physicians will be more responsible for chronic illness and coordination of chronic illness. So this is not unique to our state. This is happening. We've supported it in this state by expanding licensure capabilities for nurse practitioners and physician's assistants. So it'd be nice to kind of get a sense of where the recent graduates have ended up, over the last couple of years, because it might help us understand more of what lies ahead.
Thank you, Commissioner, and we will follow up with you on the Senator Friedman's bill.
I wasn't suggesting just me. I think
yes.
all of us. It's you plural. Okay, great.
Yep.
Thanks.
All right, David.
Continue. This was my last slide in this section. So we've reached the end of our review of last year's recommendation. So, happy to take final comments, questions, things that I think Commissioner Cohen, you mentioned, workforce as an area that, wasn't highlighted as much last year. Are there other areas that you'd encourage us to, look at and consider as we're putting this all together? And as soon as I mentioned workforce, I saw Commissioner Foley's hand come up. So I will turn it over to Commissioner Foley.
Try as you might to put me into that bucket, David. No, clearly we have to add workforce as a major component, not just at the licensed level, but at every level within the healthcare workforce. And look forward to the HPC's report that you're, working on or coming up shortly with. I don't know what that timing is. My comment was more just like, I've been listening and paying attention to the conversation, and I think there's a lot of global big picture pieces, and then smaller kind of in the weeds policy recommendations. And I think it goes to Don's point earlier, like looking back at what we went through and kind of how does it all fit with recommendations going forward. And I'd really push us to come back with, like, we have a broad set of policy recommendations and then very specific things that we think are urgently important. I think sometimes when we go, too many things means not all of them are taking up. Is there a way to to strengthen the agenda by picking a number of things that need to happen more urgently, and maybe there's some longer term things that we need to consider and better understand? Clearly, all the economic and worldwide events impacting healthcare, and clearly still going through a pandemic, and the impact that's having on the workforce and patients and community and everything all involved. There's clearly longer, bigger picture things that we have to figure out. And then what are some of the shorter term things that we think we need to get in place now? And then how do we structure the cost trends hearing around that? I like the notion of, what's the plan? If these economic impacts are real, and they are real, and what's the plan for the hospital communities and others to address that? I think is a really important area. You referenced Michael Curry and the great work that's going on there. Maybe we have a section about the healthcare equity lens issues and kind of some of the recommendations in workforce. It seems like those are the three big pieces for me that I pull back from this conversation is, what's the future of healthcare look like, and how is it accelerating based upon forces within and not in our control? Two, how does that impact the healthcare equity lens that we have, and kind of what are we learning, and how do we need to do better in that space? And three, what are we doing about the workforce to be able to take on and deliver the care that's necessary to support a healthcare equity lens and a transformation of the healthcare system? And so how do those three kind of main buckets, in my mind, from what I heard, help to formulate what we're looking at are the cost trends hearings and the policy recommendations going forward, and really hone in on critical things that have to happen now and longer term things we need to be thinking about policy wise to the future of the healthcare market and how it's being delivered, not just here, but across the country. So
I want to go back to Chris's comment about sort of stress testing the system and thinking about 23. And I think he's right on. And, we have enough data to know which of those systems that we should be looking more closely at because of their, the margins and profitability. But I also want to include in that we're seeing some more consolidation of service and devolution of service, if you will. We've seen it in pediatric care. We're seeing it out here in oncology. And so I think we as a commission need to be thinking sort of big picture statewide. What do we want to protect against as all of these forces come together to make sure that residents still have access to good quality health care, near where they live?
David?
We have one more hand, Commissioner Berwick.
Yeah, go ahead.
Yeah, I like the comments that Tim Foley and Marty just made. I think they're very, very helpful. A couple of thoughts, David. One is not to lose the focused point about authority to treat different places differently. I think there's one focus message to get through. Make sure that's clear. It's in item 1, but I think we all said maybe not with enough punch. I think that I'm delighted to know about the Princeton conference focus on workforce. It's the number one thing I'm hearing. And so I totally endorse everybody else's suggestion that we have a strong workforce focus. Well, I guess, I have a couple other ideas, but I think we got enough on the table. I think that this idea that actually Chris catalyzed about what's the plan if some of the worst case scenarios play out is important. And I think we can call that question and at least not get caught napping if things play out as badly as some of the worst case scenarios look. Thanks, David.
Madam Secretary.
This is a fluid conversation today. I would just remind all of us that as we have these conversations, the central mission of this commission is a health cost lens. So in all of these conversations, all of which are important, It is also when we talk about workforce, how is that helping us in both quality and cost? When we talk about equity, it is about quality and what are we doing about healthcare cost drivers. So I always feel like I'm like the skunk at the garden party because these are all extraordinarily important. But this commission was created to really hone in on the cost drivers of our high quality, not completely equitable healthcare system in Massachusetts. So that is the one thing I would just remind all of us of what our central mission is on this commission.
Well, yeah, thank you, Madam. That was, you said it in ways I couldn't, but that was my statement as well. One final thought on my part is I think our staff has done a phenomenal job of trying to understand the overall impact of COVID on the delivery system. And I would really strongly recommend that we intensify that effort. With all due respect to all of us, including myself, there is more attempt to use COVID as a justification for us pushing our own agenda rather than seeing what COVID is actually doing. And if, maybe it's just an old guy who's been at this for 60 years, turns out that our healthcare system is amazingly resilient. And while we've made major changes in terms of the delivery of care over the last 60 years, it's amazing how similar it is today, and that the issues that are being discussed, I could sort of replicate in 1972. Our healthcare system is bouncing back. And the comment as well, let's ask what the delivery system people are doing. And I think we know what they're doing. They want 10 to 20% increases so they can continue to do what they were doing. And so all I would say is we need to sort of expand and intensify our understanding of what happened under COVID, what is what was temporary and what is permanent, and where we are likely to be in 2023 versus where we were in 2019. And while that was discussed in previous, I think it needs to be brought up as one of the key ingredients of our recommendations. And with that, I will I wish you all the best, that I will watch you very intensely because I'm sure you're going to make some really wonderful decisions. Thank you so much.
I don't know, Stuart. There's these cost trend hearings come fall. You never know.
We're going to swear him in as the first testifier under oath this time.
Oh, no.
Well, thank you, commissioners. This was, a really insightful conversation, and I'm glad we got to talk about both these recommendations and some of the bigger picture concerns and questions. And you've given us, as always, just a tremendous amount to work on and think about. We will be back in touch with you on these recommendations and on the final cost trends report over the summer as we put pen to paper on these topical areas and others. And so if you have other comments, feedback, ideas that come to you later, please reach out and know that we're going to be reaching out to you too. So more to come on this. So the final agenda item for today's meeting is the executive director's report, and just have a very brief number of updates to give to you in this report. So I will kick us off by just giving an update on the next slide regarding the performance improvement plan, which was filed by MGB with the HPC in May. So as I reviewed at the last board meeting, this proposal is being reviewed closely by the HPC staff in coordination with our experts. And per the regulation, we have been continuing to consult and work with MGB in a constructive and positive manner to understand the different component pieces of their filed plan and strategies. So these conversations are ongoing and I think of mutual benefit to both sides. So that is why we are not proposing to take a vote on the proposal today. But I do have an expectation that we will bring this up for a vote at the September board meeting at that time. On the next slide, we have our brief market updates. So I'm going to actually ask Sasha to just run through these really quickly.
Absolutely. Thank you, David. Good afternoon, commissioners and public. Since 2013, when we first began receiving notices of material change, we received notice of 143 provider transactions. As you can see here, formation of contracting entities, including joint ventures, have been the most frequent, followed by clinical affiliations and transactions involving physician groups. On the next slide, you can see that we moved not to proceed to a cost of market impact review on one transaction since our last board meeting. That was the proposed transaction between Signature Healthcare, South Shore Health System, Sturdy Memorial Hospital, and Southeast Massachusetts Behavioral Health, which is a subsidiary of US Health Vest, to create, operate, and own a new psychiatric hospital in southeastern Massachusetts. In our preliminary examination of the transaction, we found limited scope for spending or market impacts. The transaction, the creation of a new hospital, obviously would lead to changes in behavioral health utilization, but we found it's unlikely that those changes would significantly increase spending. And obviously those plans would also increase inpatient psychiatric capacity in southeastern Massachusetts. And with regard to clinical quality, it's our understanding that following the transaction, the hospital will be subject to licensure and ongoing oversight by our colleagues at the Department of Mental Health. On the next slide, you can see that there are 4 transactions still under review. 2 of these you've heard about before, the proposed acquisition of Franciscan Hospital for Children by Boston Children's Hospital, as well as the proposed joint venture between Melrose Wakefield Healthcare and Shields Healthcare Group to create and operate a joint clinic licensed PET CT service for patients in Melrose Wakefield service area. We've received 2 new MCNs since our last board meeting. The first is the proposed clinical affiliation between Children's Medical Center Corporation, the parent of Boston Children's Hospital, and Tufts Medicine, which has as its anchor hospital, Tufts Medical Center. The proposed affiliation includes a professional services agreement under which children's affiliated physicians foundation would lease pediatric specialists to Tufts to operate services, ambulatory services of the NICU at Tufts Medical Center. The second component of the agreement is a preferred provider agreement under which patients that require services that have been discontinued at Tufts Medical Center, including medical, surgical, inpatient services, would be referred to Children's Hospital Boston, and Tufts risk patients would receive discounted hospital rates at Children's under that agreement. The second notice that we've received is a proposed joint venture between Tufts Medicine and Acadia Healthcare Company, which is a national behavioral health services provider that operates 2 behavioral health hospitals in Haverhill and Dartmouth, as well as a number of substance use disorder treatment facilities in Massachusetts. And under the proposed transaction, Tufts and Acadia would form an LLC that would construct, own, and operate a new psychiatric hospital in Malden. So that is our summary of changes. If anyone has any questions, welcome them. Otherwise, I'll hand it back over to David Seltz.
Seeing no questions at this time, I will hand the meeting over to Colleen Elsemeyer to provide an update on agency activities and events.
Thank you so much, Director Seltz. Okay, so starting here with my just my usual slide to quickly highlight some of the work that's been published recently. Everything, as always, is posted on our website, mass.gov/HPC, including the slide deck from today's meeting is already posted there. Last month was a very busy one. As I'm sure you'll all remember from our last meeting, we've released a number of items related to the fantastic work of our Shift Care Challenge awardees. We've released the evaluation report on this program, an impact brief, and the video we shared at the last meeting. Those are all available on our website. Still in the pipeline, we're finalizing the issue of data points related to urgent care centers in Massachusetts. We have a spotlight on some HPC investment programs that are partnering with emergency medical service providers and a number of reports to the legislature, including our workforce report, which has been discussed at length in this meeting. We've met with a number of commissioners and stakeholders this year to better understand the scope and scale of that issue. We've got a report coming out on telehealth. And last but not least, we can't forget our 2022 cost trends report, which you will all be receiving for review later this summer and which will be published this fall. So that's all recent release and upcoming publications. On the next slide, I'm going to be brief on this because we have talked a lot about health equity already today, but I'm just here to give you a very brief update on the HPC's progress when it comes to advancing health equity at the HPC and within the HPC. So as you'll recall, in 2020, we announced an explicit commitment to addressing healthcare disparities, advancing health equity, and promoting social and economic justice throughout our work as part of our cost containment and quality improvement mission and agenda. You'll see here on the slide, the HPC's mission statement clearly identifies equity for all residents of the Commonwealth as a core concern, and as does our founding statute, Chapter 224. So since then, the HPC has worked to embed health equity concepts in all aspects of our cost containment and quality work, applying all 4 of our core strategies to the goal of advancing equity here in the Commonwealth. So those are research and report, convene, watchdog, and partner. The good news is that this work has progressed significantly over the last 2 years. And as an agency and as individuals, we've continued to educate ourselves with the impact of systemic racism, and we're seeking to promote diversity, equity, inclusion, and belonging in our workplace as well. So that has been going well. And yes, on the rest slide, on this slide, just reporting to you on the 2 major areas of progress today. We've produced a large amount of work in the past 2 years concentrated on equity and disparities. And then second, we've also really focused on how we embed an equity lens into our internal processes. There's just a brief list of activities on this slide. I would just highlight a couple. For example, we talked to you at the previous Care Delivery Transformation Committee meeting about the Equity in Every Project tool for addressing health equity in our external facing work. That's something that our Healthcare Transformation Innovation Department has been doing. And we also recognize always that in addition to our internal engagement and sharing of resources within the agency, it's important to stay up to date in the latest and best research on health disparities, especially when it comes to equity concerns within market and provider changes in the marketplace. So that's what we've been doing internally. So more on our progress, including a list of specific work outputs with a focus on equity and health disparities, can all be found on our health equity webpage on our website. There you'll also find an updated version of the Health Equity Practice and Style Guide, which was published last July. We've added additional language on mental health, substance use, geography, residency status, weight stigma. So that has been updated and will continue to be updated on a quarterly basis as needed. Obviously, much more to say on this topic, but please do check out our website. This morning, we did post a much longer version of this slide deck in particular. So if you're interested in that, please do check it out. All right, on the next slide, yes, I'm closing out here with a save the date to the Super Bowl of Healthcare, an event that we have coming up in less than 4 months, the 10th annual Healthcare Cost Trends hearing. This is going to take place on Wednesday, November 2nd, save the date, and will be held in commemoration with the HPC's 10th anniversary. At the next board meeting, that's September 14th at 12 p.m., we'll be talking about themes, topics, witnesses, keynote speakers, everything that we want to drill down into. Great kicking off point coming off your discussion today. And we've talked a lot about 10 years and 10 years under the leadership of our chair, Chair Altman, our inaugural chair, which is the perfect segue into the next slide, where you will see a photo from the bill signing of our enabling legislation, Chapter 224 of the Acts of 2012, signed into law by Governor Deval Patrick in August of 2012. It actually became effective in November. So the anniversary really lasts for several months, depending on where your starting point is, from August to November of this year. So obviously, this is a monumental milestone for the HPC, as well as for our interagency and legislative partners and the whole healthcare industry writ large, who've worked with us over the last decade or more to advance our goals and mission. So we have a lot of activities planned to celebrate this. First of which is obviously going to be the cost trends hearing on November 2nd. We'll be rolling out a multimedia component, a video slideshow in recognition of the milestone. And yes, as highlighted earlier, the hearing will be accompanied by a celebratory event for commissioners and our key stakeholders after the hearing, which will, of course, now be held in honor of our dear Dr. Stuart Altman. The second main activity associated with the 10-year anniversary is obviously our 10th set of cost trends report policy recommendations, obviously as discussed at length. Earlier in this meeting, the report and recommendations are going to be released concurrently with the 10-year anniversary of our cost containment law this fall. So I think even more impactful this year than ever, and also providing a policy roadmap for a new administration coming in January and a new legislature coming in January 2023 as well. Finally, the third main activity, which I know all of our stakeholders will be thrilled to hear about, will include the launch of a brand new HPC website. We have been working behind the scenes throughout the pandemic on a new and improved HPC website, which is set to launch at the end of this year. So obviously more to come on this, but specifically for the anniversary, we will be hosting a big interactive timeline, milestone accomplishments in HPC history, HPC by the numbers, infographics, all kinds of good stuff, highlighting a decade of the HPC. So that was a whirlwind, but we are still looking forward to celebrating our chair and our 10-year anniversary with you all. So lots of special programming to come up. Stay tuned for more information. Save the date for the hearing. And that's it for me. Back to you, Director Seltz.
Thank you, Colleen. Great update. So we have one final piece of business today, which will require a vote, which is related to our budget. So our HPC budget is set every year in the state budget. Our appropriation is set. The state budget is still under negotiation between the House and Senate and has not been released yet, nor has the governor had an opportunity to review. So the governor and the legislature agreed on an interim budget, which would continue to fund departments at their previous fiscal year level. So you can see here the kind of the timeline of the different budget bills and the appropriations that were included in each of them. I would note that both the House and the Senate does include the exact same number for the HPC. However, given that this budget is still under negotiation, what we're proposing here today is to vote on a continuing budget resolution that would allow us to continue to operate the HPC at the previous fiscal year level until such time as the state budget is completed and we can come back to the board with a full budget vote and proposal. We did meet yesterday with the Administration and Finance Committee of the HPC to review this plan. I will let them speak for themselves, but the vote on the next slide is what we're asking for today to just move this forward until such time as the state budget is finalized.
So moved.
Second.
Well, let me just say that the committee met yesterday, of Administration and Finance, and we went through both the activities in the previous year and the expected budget for the forthcoming year, and are uniformly in agreement with this motion to move the budget as a temporary until the final budget is approved. Go ahead, Madam Secretary.
I make the motion.
All right. Okay, is there a second?
Second.
I hear a second. All those we have to do this by our wonderful Deputy Executive Director. Go through this one more time. Colleen?
Mr. Chair, your final vote as chair of the.
I approve.
Thank you. Vice Chair Cohen,
Aye.
Commissioner Berwick,
Aye.
Commissioner Blakeney,
Aye.
Commissioner Cutler,
Aye.
Commissioner Foley. Tim.
Aye.
Thank you. Commissioner Haupt,
Aye.
Commissioner Master Giovanni,
Aye.
Secretary Sutters,
Aye.
and Commissioner Roeder.
Aye.
Thank you.
So, David, you have, or Colleen, the schedule for the upcoming meetings?
So we will be meeting together again on September 14th. And thank you for a great meeting today. We will be working hard over the summer. We hope that you all have a great summer. And we will be in touch. And again, a final thank you to Stuart Altman for being our chair and leader for the past 10 years.
All the best, Stuart.
Thank you all so much. It's been
We expect to see you around, Stuart.
Oh, I'm looking forward to it. What a wonderful opportunity you've given me. Thank you so much.
Thank you,
Thank
Stuart,
you.
for everything. Be well.
Thank you, Stuart.
Thank you,
Take care,
Stuart.
everyone.